So hello everyone, my name is Stephanie Heberle from THện, and today I would like to introduce Michael Sommers. He is Associate Chief in Pediatric Nephrology in the Division of Nephrology at Boston Children's Hospital, where he also serves as the Medical Director of the Renal Dialysis Unit and the Director of Clinical Service. Dr. Sommers also is an Associate Professor in Pediatrics at Harvard Medical School. He has been part of the numerous international and national research and quality improvements initiatives focused on kidney disease in children and has leadership position in many professional societies and organizations. Thank you very much, Michael, for doing this webinar. We are looking forward to your presentation.
Thank you, Stephanie, and thank you for inviting me to spend some time with you today to talk about acute post-streptococcal glomerulonephritis. Here in Boston today, it's a rainy and gloomy day, but it's the beginning of spring and the leaves are just starting to come out. So I'm trying to stay happy despite the rain. But this is making my morning better to be able to be with you. So I want to start out with a couple of cases. These are actual cases of kids that I had the opportunity to take care of, and they showed up actually within 2 weeks of one another. And the first case is of Thomas, who is a healthy 6-year-old boy who had been treated for strep throat 2 weeks before I saw him. And he presented now with 2 days of increasing swelling and the onset of urine that the family described as dark. And when you looked at the urine, it was tea-colored. On exam, his weight was up 2 kilograms from when he was seen a few weeks before for his strep throat. He was hypertensive, and he had some mild edema. His urinalysis showed hematuria and proteinuria, and he had red cells on microscopy, and I could see occasional red cell casts. And he had fairly significant proteinuria when I quantified his proteinuria by protein to creatinine ratio. His other labs were notable for fairly normal electrolytes and creatinine. He had a low normal serum albumin. His C3 complement level was quite depressed, and he had an elevated ASO titer, as you might expect with his recent diagnosis of strep throat. We admitted him for blood pressure management. He was treated with furosemide and some amlodipine. And very quickly, his blood pressure improved. He diuresed and his weight came down. He was discharged home on some furosemide. We saw him back in clinic, and by 2 weeks, his urine was clear macroscopically. His blood pressure was normal. His weight was back to the baseline, and we were able to stop his furosemide. When we saw him at 2 months, he again continued to be normotensive, had a normal physical examination. His urinalysis had just a bit of microscopic hematuria, but no proteinuria, a normal urine sediment, and his C3 complement levels were normal. And when we saw him at a year of follow-up, he was completely normal with normal blood pressure, normal physical exam, and completely normal urinalysis. Now, I like to contrast Thomas with Ian, and Ian presented a couple weeks after Thomas. He was also a healthy boy, a little bit older at 10 years, but he had also recently been treated for a strep throat. And for the last 2 days, he'd had some decreased intake, had been vomiting a bit, but the family noticed that his urine output seemed to be decreased and his urine looked darker. On exam, his weight was also up 2 kilos from when he was seen for his strep throat. He also was hypertensive and had a little bit of extremity edema. His urinalysis showed hematuria and proteinuria, lots of red cells, occasional red cell casts, as well as some granular and hyaline casts. But his laboratories were more remarkable. He had elevated BUN and creatinine in addition to the depressed C3 and the elevated ASO titers. So we admitted him for management of his acute kidney injury and for his blood pressure. But unfortunately, over the next 12 hours, he became anuric. He didn't respond to furosemide after we were sure that his intravascular volume was replete. He remained hypertensive despite us giving him intravenous antihypertensive agents, and his BUN and creatinine increased further. So he underwent a kidney biopsy that showed crescentic change in the majority of his glomeruli. We pulsed him with methylprednisolone, but unfortunately he stopped making any urine. We needed to start intermittent hemodialysis because of his renal failure and his ongoing volume excess. And he actually never regained any urine output. We repeated a kidney biopsy about 2 months after presentation, and it showed irreversible changes at that point, consistent with him having progressed to end-stage kidney disease. He was maintained on intermittent hemodialysis for 6 months and then received a living donor kidney transplant and is now doing quite well. So we have the same disease, but different outcomes in 2 kids, both of them presenting with strep pharyngitis that was promptly treated. Both developed gross hematuria and volume overload, but one of them had dramatic AKI from what seems to have been a rapidly progressive glomerulonephritis. Thomas recovered clinically rather quickly, while Ian progressed to end-stage kidney disease in the very same time frame. So I use those cases to kind of jumpstart what we're going to discuss today. And what we're going to discuss is going to be very clinically oriented and what I think people should know about approaching acute post-streptococcal glomerulonephritis. I hope what you'll take away from the next half hour is an ability to recognize the pathophysiology of acute post-streptococcal GN and how it can be used as a paradigm for an immune complex nephritis. I want people to understand the epidemiology of APSGN and its clinical presentation. I want you to be able to describe what you do for a diagnostic evaluation and management strategies. And lastly, we're going to talk a bit about outcomes seen with these kids and necessary kidney follow-up. To start things off, I'd like to do a poll. I've been told that I'm going to be talking to people with all kinds of different experience here. So for me to understand my audience a bit better, I'd like you to tell me about your exposure to this topic. Is it something that you know generally nothing about? Your knowledge from it is only what you've been taught in a classroom or what you've read? You've seen a few patients, or you've seen more than a few patients? I'll give you some time for people to answer that poll. All right.
Michael, can you see the result?
I can see it. Now I can see it. So, I see that I don't have very many newbies in the audience today, but maybe about a third of people have less experience with acute post-streptococcal GN, and 2/3 look like they're quite the veteran with it all. All right. So let's talk a bit about pathophysiology and how could an immune response to a strep infection result in a glomerulonephritis. And generally, the thought is that there are one of 4 different mechanisms going on. The first mechanism is that there's some circulating immune complex that includes a streptococcal antigen deposit, streptococcal antigen antibody complex that deposits in the kidney. And this is outlined in this diagram on the right-hand side in number 1. The second main thought is that this could all be mediated by streptococcal antigens depositing within the glomerular basement membrane, and then subsequently there being antibody binding and immune complex formation. And this is again shown in the diagram with the number 2. The third and fourth potential mechanisms are a little bit more interesting. The third mechanism is what's called molecular mimicry, and that the antibodies to the streptococcal antigen are able to cross-react to components of the glomerulus instead of just merely interacting with the streptococcal antigen. This allows immune complex formation to occur. And lastly, there have been others who've looked at whether the neuraminidase that Streptococcus can excrete can actually modify your native IgG, perhaps by changing the terminal sialic acid. And it then creates an IgG, which actually can have autoimmune potential. So some active change of your own IgG, which creates then this autoimmunity. In any case, what's underlying this pathophysiology is the ability for the strep, some sort of antigen with the strep, to start mediating this immune response. Now, the nephritogenic antigens that have been proposed are many in number, but more recently, there's been a lot of attention on 2 putative antigens. One that's called the nephritis-associated plasmin receptor, which is a glycolytic enzyme. And a lot more focus recently on the streptococcal pyrogenic exotoxin B, a proteinase that's secreted by the streptococci, which is thought to potentially be mediating this. There's been some interesting work looking at the levels of SPEB in the serum of individuals with acute post-streptococcal GN. There's been a lot of work looking at the immune deposits and actually being able to isolate the SPEB from these immune deposits. So both of these, a lot of attention recently. It's probably true, however, that there's not one single nephritogenic antigen. And remember, I said we're using post-strep as kind of this paradigm for an immune complex nephritis. And certainly there are a whole host of other infections, bacterial, viral, fungal, protozoal, that have been described mediating a post-infectious GN. So we know that that these sorts of post-infectious issues aren't related to one specific antigen and the immune response that's triggered by that. Again, what's interesting with both of these proposed nephritogenic antigens is their activation of the alternative complement pathway. They're very potent activators of that, and certainly one of the hallmarks of acute post-strep GN is this turning on of the complement cascade. So again, to kind of summarize what we've just talked about in terms of the pathophysiology, you get antigen and antibody reaction and immune deposition. Now, we all remember from our renal physiology classes that if this immune complex deposition is in a subendothelial location, then it's going to be associated with inflammation. And because of its proximity to blood in the glomerular capillary, there can be complement consumption as part of that inflammatory reaction. On the other hand, immune complexes that deposit in a subepithelial position are going to be associated more with alterations in the podocyte, with perturbations in the glomerular filter in terms of blocking protein leaking out, and thus associated with proteinuria. So kind of where you have this immune complex deposition allows these broader phenotypes, whether you're nephrotic, whether you're nephritic, or potentially whether there's this overlap. With someone who's nephrotic, should have more changes affecting the subepithelial region and the podocytes, someone more nephritic with subendothelial localization of their deposits more than subepithelial. Now, final word about pathophysiology for all of you who are wondering when we're going to actually move into something more clinical. And that's just to look at some pictures from a kidney biopsy to appreciate the histology. So on light microscopy, you're going to see very proliferative change, and it's often very exudative in its acute phases with lots of neutrophilic infiltration. The kind of clinical findings can vary in the spectrum, such as the cases of Thomas and Ian. And in Ian's case, there was a profound amount of crescent formation, although in your typical acute post-streptococcal GN, crescent formation is much less common. On immunostaining, the immunofluorescence is most notable for dominant C3 and IgG. And this deposition is usually along the glomerular capillary, can also be in the some mesangial deposition. You'll often hear the C3 deposition described by terms such as starry sky. And finally, the electron microscopy, kind of the prototypical electron microscopy, includes pictures with these subepithelial deposits, what are called humps. So these dome-like electron-dense deposits localized in the subepithelial area. But as we've discussed with the pathophysiology, you can certainly and very frequently see subendothelial deposits as well. So just to move on and transition, I'd like to ask a second poll question, and that's in a child with acute post-streptococcal GN who has a negative throat culture and no active infection. I'd like to know if you'd provide antibiotics to that child. Can you tell me yes or no? All right. And our results, about a quarter of people said yes, they'd give antibiotics, 3/4 say no. We're going to actually talk about this a little bit later on. But let's transition to some words about epidemiology. So most kids who are affected with an acute post-strep GN will be between 2 and 18 years of age, but the peak prevalence is really the early school year ages, 5 to 10 years of age, especially 6, 7, 8 years of age. It's an entity that's very uncommon in the very young. So those kids less than 2 to 3, you tend not to see kids with post-strep GN. And perhaps this is related to less strep carriage, colonization. You know, we're all taught as pediatricians that the little kids are less likely to get strep pharyngitis. It could be some potential immune factors or host factors as well. In terms of epidemiology and sex, there's a preponderance of boys. Most case series have shown this consistently. Some series with up to 80% of those affected being boys, most of them's closer to about 60%. And it's unclear why this is the case, because when you look at the overall prevalence of group A strep, it doesn't vary between boys and girls. And yet this manifestation of kidney disease after a strep infection does seem to disproportionately affect boys. The scope of disease is significant. So worldwide, it's estimated that there's 500,000 cases annually and up to 5,000 deaths. And there are marked disparities in prevalence. And similar to streptococcal infection in general, acute post-streptococcal GN is especially seen in economically disadvantaged populations. And of those 500,000 cases annually worldwide, it's estimated that more than 90% of them actually come from areas of the world where there are fewer resources, or from areas where, as I said, there's less infrastructure, less access to medical care, less public health services, and more economic disadvantages. A very nice meta-analysis that looked at 11 population studies around the world showed that the incidence of acute post-strep GN varied from 2 per 100,000 population in more developed, more economically advantaged areas to 24 cases per 100,000 in less developed economies. There's also a seasonal variation, which again makes sense because streptococcal disease tends to be more common in colder months in terms of respiratory illness. And it's more associated with skin infections leading to acute post-streptococcal GN in warmer months. So during this summertime into the early fall, you're more likely to see some of the skin manifestations leading to GN, whereas that's rare to see during the colder weather. Epidemic disease has been described, and there's been a lot of work to understand clinically and also the pathophysiology of strep based on these epidemics. Epidemics of strep and post-strep GN are still described nowadays, most often again in areas with kind of higher baseline rates of streptococcal disease. But as I alluded to, lots of very interesting work in the literature from the United States, the state of Minnesota, and the central part of the US in the Red Lake Reservation, and from the indigenous Aboriginal community in Central Australia. Certainly in the setting of epidemic disease, that may alter the clinician's approach to typical diagnosis and management versus sporadic disease, much as the approach to any disease state in an epidemic varies from when the disease is much less prevalent. A lot of this work has led to understanding of these nephritogenic strains of strep, and especially for respiratory disease. M types 1, 2, 4, and 12 have been implicated in lots of cases of strep mediated GN. And for skin disease, M types 47, 49, and 55. Now, a word about clinical presentation. So again, this is a post-infectious glomerulonephritis. So the infection happens first, there's some latent period, and then the nephritis occurs. And the latent period is often somewhere between a week and 6 weeks, more frequently a week to about 3 weeks. But subclinical disease makes that time course difficult to pinpoint. So people often forget illnesses that are mild or may not even have made any note of an illness. So again, trying to figure out the time frame can be difficult clinically. Now, anecdotally, there have been reports that respiratory-related illness has an onset sooner than skin-related illness. And I'll tell you that, when I went to medical school almost 40 years ago, I was told that when the very first thing I remember being told about acute post-strep GN was that if it was respiratory-related, it came on sooner than skin-related. And you'll still see that written, but there are a couple of very interesting studies that have actually very meticulously looked at the time course, and they've shown that there really isn't this significant disparity in a latent period between nephritis related to pharyngitis and nephritis related to impetigo or skin infection. And in fact, both of those studies showed that the latent period for respiratory illness was about 9 or 10 days, and for skin infection was just a bit above 10 days. So very, very similar. But again, the takeaway message is that there has to be this latent period. There should be this latent period. And the onset of the nephritis should not be at the same time as the illness. That should trigger thoughts about another etiology. In terms of preceding illness and what patients will tell you they've experienced in the weeks prior to presenting with their kidney disease, there are a couple of studies that I wanted to bring to your attention. One was a cohort of 125 Israeli children. And when they presented, people were able to discern a history of pharyngitis in almost half, some other sort of respiratory infection in a quarter. 15% of those kids totally asymptomatic. No one could remember any sort of illness over the prior 6 weeks. 10% some GI illness, and only 5% skin infection. A larger cohort, almost 500 kids from Armenia over a 5-year period of time. Again, we see this respiratory predisposition, about 3/4 of the kids having either a cold or pharyngitis in the weeks prior to presenting with kidney disease. Kind of a larger proportion with impetigo in the Armenian group, but again, 10, 15%. Again, a good component, 10% asymptomatic. So again, takeaway from this is a respiratory associated illness is going to commonly be reported. Skin disease, less commonly reported. So probably 6 to 7-fold difference there. But a good proportion, 10, 15%, aren't going to be able to tell you about any preceding disease. Now, when we look from a kidney standpoint, what we're interested in as clinical nephrologists at the clinical presentation of these kids, again, remember we talked about endothelial deposition, inflammation, complement consumption, this process that goes on that very much favors a nephritic process with an acute post-strep GN. So almost all the kids will have hematuria, microscopic hematuria, but discolored urine, gross hematuria is very, very frequent. And most of the larger cohorts have described it in 60 to 80% of kids. Similarly, hypertension, very, very, very frequent. Again, mediated by the salt and water avidity that you see with a nephritis, reported in most of the large series in 2/3 to 3/4 of the kids. In terms of decreases in your GFR or alterations in urine flow or oliguria, anuria, both are seen usually 30 to 40% of most cohorts, but not nearly as frequent as the hematuria or the hypertension. In terms of this broader clinical phenotype, about 40% of kids in most of the larger series will actually meet the definition for a nephritic syndrome, so have all 4 of those components we just talked about. About 10% of those kids who are nephritic will also be nephrotic, so they're nephrotic nephritics. And only about 5%, sometimes a little bit less than that in the larger cohorts, will present with a purely nephrotic presentation. Now, again, going back to those 2 cases I first presented, the clinical course, the spectrum of disease is very broad, from completely asymptomatic to having symptoms but recovering quickly, like Thomas, to kidney failure, as we saw with Ian. And there can be serious sequelae in these kids acutely, even the kids who may go on to have complete recovery. So their volume overload predisposes them to hypertension. And about 5% of most large cohorts will describe kids having hypertensive emergencies or urgencies, seizures, encephalopathy related to the volume overload and the hypertension. So any child who presents with hypertension, that's why we tend to have a very low threshold to admit those children and to monitor them closely, to potentially try to diurese them and to get their blood pressure under control. Similarly, although it's infrequent, there are kids who can develop symptomatic pulmonary edema and congestive heart failure. Again, most of the larger cohorts say it will be somewhere between 5 to 15% of kids. Now, that's not to say that if you do a chest radiograph, you may not find changes consistent with some pulmonary congestion. And there have been some studies looking more systematically at chest radiographs in kids with post-strep GN that estimated about half of them can see radiographic changes. In terms of progressing to kidney failure from their acute kidney injury and needing dialysis, or needing dialysis urgently because of their volume overload, relatively uncommon. So again, 1 to 2% of most large cohorts from a kind of mixed populations. Some of the case series that are reported in the literature from populations that are predisposed to more aggressive forms of post-strep GN will show a higher proportion of kids needing some sort of kidney replacement therapy. Again, most of the kids who go on to need dialysis have had very severe acute kidney injury, and many of those related to a rapidly progressive GN. In terms of the diagnostic evaluation you're going to do for a child who you suspect may have this process, your physical exam is very much focused on looking if there's any active infection requiring treatment. Most of these kids are not going to have an active infection and are not going to require treatment. And again, trying to assess their degree of volume overload, especially by assessing their blood pressure, checking them for edema, auscultation, getting a sense of the urgency of their need for any diuresis or blood pressure control. In terms of laboratory studies, your urinalysis is going to, of course, to show hematuria. If you're able to look at the urine yourself, you should appreciate dysmorphic urinary red cells. You're going to see red cell casts rather readily. There'll be variable proteinuria, and the urine protein to creatinine ratio can range from normal to nephrotic. In terms of the blood work, most people will get a C3 complement level, which should be depressed. There's frequently, if there's the suspicion for this being strep mediated, some strep specific tests to look for recent infection, either an ASO titer or anti-DNase-B. People will often check albumin in proteinuric kids and of course get a baseline assessment of creatinine. Very often other laboratory work is done, but this is obviously studies that almost all children have. In terms of imaging, many children have no imaging or requirement for no imaging whatsoever. There's the potential need for a chest radiograph, as we've also discussed, and oftentimes there's a consideration of a kidney ultrasound. I will say that ultrasound's probably done more often than it needs to be done, but in children who have a degree of kidney failure, who may have some oliguria, it's very frequently done to get some sense of the anatomy and to make sure there's no other process that it can't be appreciated any other way. When you do an ultrasound of a child with post-strep GN, Typical findings are some echogenic parenchyma. Sometimes there can be some mild generalized swelling of the kidney and a greater size than what you would expect. But again, more non-specific imaging changes. A word about specific strep diagnostic testing, because I'm often asked, you know, is there one specific test that really you'd want to do in terms of thinking that it's post-strep GN? And there was a very nice study that looked at this cohort of kids with acute post-strep GN and compared them to a group of kids that were similar in age and sex, but were hospitalized for other clinical reasons, and at baseline were healthy kids. And you can see that, you know, when you compare these two cohorts, the C3 levels depressed almost universally in this acute post-strep cohort, whereas none of the hospitalized controls have a depressed C3 level. The ASO titer is increased in only 70% of these acute post-strep kids, all of whom clinically were known to have had strep disease, versus 18% of the hospitalized controls. Again, telling you that, you know, strep disease is common in children, and there's going to be a baseline level of positivity with ASO titers. And in terms of positive throat cultures, again, not much difference between the two groups. Again, remember, acute post-strep is post-infectious. So by the time most of these kids, if they had a strep pharyngitis, present with their nephritis, their strep pharyngitis has been treated or has abated. So again, takeaway message from there, in terms of these labs that we often are looking at, C3 depression is the most common positive lab finding. And that C3 level can be profoundly low, but it tends to rebound quickly as well. So often the rebound within 3 to 4 weeks. Depressed levels beyond 3 months, however, should prompt consideration of other diagnoses and potentially a kidney biopsy. In terms of ASO titers, they tend to increase within a week of the initial infection. They peak within 3 to 5 weeks. If someone's presenting a little bit later, then the ASO titer may not be as high as what you would imagine. Anti-DNase B, there's some thought that it may be more sensitive in certain populations. There's some reports of its increased utility after skin infections. Again, it increases a little bit later in the time course, peaking within 6 to 8 weeks. So let's move to poll question 3 here. So in a child with acute post-strep GN and controlled blood pressure, would you restrict their physical activity? Yes or no? All right. Let's see what our response shows. So again, about a quarter of people are going to restrict it, 3/4 aren't going to restrict the activity. And again, I'm going to leave you in a bit of suspense. We're going to talk about this pretty quickly. Let me So let's talk now about management and general medical care. So salt and fluid restriction is very important to moderate the volume overload that we've talked about that caused so much in terms of significant sequelae. So with this GN, you're going to be salt and water avid, and most of the kids will benefit from some sort of fluid restriction or salt restriction when they're acutely ill and having issues with volume overload. Loop diuretics are incredibly effective, and using something like furosemide can not only help to normalize the blood pressure very quickly, but will help with diuresis and volume control. And Vasodilator therapy is also an important adjunct for those patients who are hypertensive. So there's often use of agents like calcium channel blockers, vasodilators like hydralazine if something intravenously needs to be used. In patients where there's concern for some alterations in their GFR, where their volume state, intravascular effective volume may be depressed, then again, most of us have concerns about using some of our other mainstays of antihypertensive therapy, notably medications with angiotensin blockade. And of course, you want to avoid new kidney insults. You want to avoid new dehydration, avoid new nephrotoxins, unless there's no other therapeutic alternative. Now, I want to say a word about some unsupported historical management, because again, you'll read old reports and old recommendations from decades ago. You'll also see patients who'll report, a history of an aunt or an uncle or a grandmother or a grandfather who had something similar to what their child had when they were a child, and this was done or that was done, and the families often ask about that. So routine antibiotic provision to patients is probably rarely needed in sporadic cases of acute post-strep GN. That may be different in an epidemic situation, but there's rarely active bacterial infection at diagnosis. Similarly, antibiotic provision to the family is rarely needed outside of epidemics or special clinical circumstances. Again, historically, kids with nephritis were often put on bed rest for protracted periods of time or told not to engage in physical activity. And there's really no evidence for efficacy of that and routine limitation to sports outside of those limitations we would normally follow for kidney issues such as uncontrolled hypertension or some other specific contraindication. So again, this relates back to both those poll questions we did earlier, where about 3/4 of you agreed with what I believe here. There has been a very interesting study in terms of family outcomes that looked at 75 kids with acute post-strep GN and meticulously looked at their other family members. None of the parents had signs or symptoms of acute post-strep GN. About 1/5 of the siblings had some urinalysis findings, usually microscopic hematuria, suggesting that potentially they had kidney involvement of strep from within the family. But only 4% of these siblings who were followed very, very closely met criteria for clinical acute post-strep GN. And again, showing you that it's going to be relatively rare that you'll find a sibling or someone else affected in the family. Although, again, as this study shows, it can occur, it's going to be rare. Let's talk just a bit about those kids like Ian who have a rapidly progressive GN. It's an uncommon finding, but it needs to be considered, especially with decreased kidney function. Certain populations seem to be at more risk for this for a variety of host factors that we just don't understand very well. The Maori community in New Zealand, especially well described in the literature. There's unfortunately no good evidence-based practice in terms of how you should treat post-strep rapidly progressive GN. So our approach to therapy is again very much historical in nature and following along how nephrologists have treated a rapidly progressive GN for decades, often going back to an era before we really were able to pinpoint the cause of rapidly progressive GN like we are now so much more frequently. There is a tendency to use pulse methylprednisolone In fact, it's mentioned in the KDIGO guidelines, but again, there's no evidence-based practice for any specific therapy. And again, the likelihood of the therapy turning around the RPGN has to do somewhat with the extent of kidney damage that's occurred. So if you have crescenteric disease and you have Bowman capsules disrupted, those glomeruli are never going to be salvaged. But certainly there are cases of kids who have crescents on biopsy who've recovered well. So overall, putting together the lab and the clinical manifestations in this diagram that I've borrowed from Elizabeth Hunt's review of post-strep GN, we're looking at the time course of GN from -2, so from prior to their presentation or diagnosis of acute post-strep GN at time point 0. So C3 levels will decrease early on, so by a week post-onset, most kids will have these very low C3 levels, and then you see the C3 levels start increasing again relatively rapidly. So by 7-8 weeks, again by 3 months, things will be normal. ASO titers go up quickly. Hypertension, again, manifestations seen early on, but you can see in those that lighter hatched bar at the bottom, by about a month, most kids who are hypertensive will no longer be hypertensive. Hematuria, again, very frequent early manifestation, persists longer. And in fact, microscopic hematuria is probably the finding that lasts the longest and has been reported to last up to a few years in some cohorts. Proteinuria following hematuria acutely, but again, tends to resolve quicker than the hematuria and much more likely to see protracted proteinuria. So in terms of general clinical expectations, take-home messages from what we've spent talking the last 45 minutes or so, most clinical signs and symptoms are going to resolve spontaneously and within weeks. Hypocomplementemia should also resolve relatively quickly, and if it persists more than 3 months, it should raise a concern for another chronic hypocomplementemic etiology of the GN. Recurrent, a word that I haven't mentioned that I did want to mention here, is that early on in the disease course, having recurrent gross hematuria is common, especially with a new acute illness. So in the first few weeks, even the first month or so after someone presents, if they get a cold, if they get another illness, it's not uncommon that their urine will become dark again. It is uncommon, though, for them to have recurrent nephritis all over again. Again, it's been described, but very, very rare that this occurs. And end-stage kidney disease, although it happened to my patient, is very, very uncommon. And most of the larger cohorts have shown that it's 1% or less. In terms of long-term outcomes, almost all affected kids will have no clinical or laboratory residuals of their nephritis by a year or two. But as with any AKI episode, even if there is a full recovery, there can be this underlying predisposition to CKD, especially in the setting of significant acute kidney injury. And a report from this Chinese cohort of 110 kids followed for up to 20 years after their acute post-strep shows this. So, 7% had residual proteinuria, 5% at that point in time had some hematuria, 5% hypertensive, small proportion with an alteration in their GFR or end-stage kidney disease. But again, you have to not forget about surveillance of those at high risk for progression, but keep calm for the vast majority of patients. Most of them are going to recover quickly and recover without significant long-term sequelae. So I hope that you found this useful. I know there are a lot of veterans out there, and for you, this may be a review of something that you're well aware of. But again, post-strep, very interesting clinical problem, something that's always a lot of fun to teach students and trainees about acute nephritis so that you can talk a lot about renal physiology. And I'm happy to answer any questions.
Thank you, Michael, for your nice presentation. Yes, indeed, we have some questions. So the first question is, should a child with post-strep crescent glomerulonephritis receive cyclophosphamide the way the rest of the immune complex crescentic glomerulonephritis are treated?
Yeah, so again, as I mentioned, the approach to treatment of someone with a rapidly progressive GN has very much followed what people have just done historically in terms of treatment. So, you know, patients often historically were treated with steroids, with cyclophosphamide, with plasmapheresis. Again, unfortunately, there's no evidence-based practice to look at rapidly progressive GN in kids with post-strep, partially because it doesn't happen that often. So I can't tell you that there is benefit to giving cyclophosphamide, as you alluded to in your question. You know, there could be some theoretic benefit because of it being an immune-mediated process. However, you know, it's my practice to give steroids, and we don't tend to give cyclophosphamide or continue other or to consider other more aggressive therapies in our very rare kids who have a rapidly progressive GN with post-strep.
Thanks. Another question is there a factor associated with more severe diseases like rapid progressive glomerulonephritis?
Are there certain factors? Yes. So I think a lot of this goes more towards host factors. So again, why is it that certain people have more aggressive disease? That probably has to do with genetic issues and other potential environmental factors in their past that could have affected their genetic composition, so epigenetic factors. I don't think we understand well. Again, as I mentioned, there are certain populations that tend to have more aggressive disease. But in terms of, you know, their preceding illness, the severity of their preceding illness, how quickly they were treated, what they were treated with, nothing like that seems to pan out in terms of predisposition to a rapidly progressive GN.
The question is, which pathway of complement is most commonly involved in post-streptococcal glomerulonephritis?
Well, you'll often read about the alternative pathway being turned on. But you know, we talked about a lot about a humoral response. You know, how that there's this antigen-antibody reaction. But you know, there is some interesting immunologic work too, looking at cellular response and changes on a cellular level as well.
How clearly and confidential can we rule in and rule out other immune-mediated glomerulonephritis, especially C3, and an apparent infectious-related glomerulonephritis?
Yeah. Yeah. So a C3 glomerulopathy, you know, if you do biopsy the child, then in a kid with post-strep GN, there is going to be a good component of IgG. Sometimes the IgG is actually dominant over the C3, but there'll be a good component of IgG. In C3 nephropathy, of course, your primary and sometimes really your only notable immunodeposit is C3. You know, in terms of other sorts of things that point towards it. You know, at diagnosis, you can't tell the trend of what your C3 will do, but certainly over time, a rapid improvement and normalization of the C3 usually helps to confirm that you're dealing with something post-infectious versus a C3 nephropathy. And again, clinical history. Although all of us have taken care of kids who ended up having a C3 nephropathy who presented with what seemed like an acute GN that was, you know, a flare of their underlying more chronic disease. So it is clinically sometimes difficult to distinguish between the acute and the chronic, which is why, again, as you see more patients, your sense of suspicion is sometimes raised in kids who aren't following along the path that you're used to seeing.
Yes. And there's another question related to this one. If it's easy to histologically differentiate post-streptococcal GN from C3 glomerulopathies.
Right, so that's what I mentioned in terms of the immunofluorescence should help you differentiate that with the C3 predominance in C3 nephropathy, and there should be a larger component of IgG and post-strep. In addition, electron microscopy may help you as well, especially if you see if the characteristic hump subepithelially.
And is there any difference in the prognosis of ASPGN with different nephrogenic strains?
Yes, that's interesting question. So, you know, some of the reports have shown that certain strains are, you know, more common in some of these populations that have more aggressive disease. But on the other hand, these strains have been shown to be present in other populations that aren't as likely to have more aggressive forms of post-strep GN as well. So.
So, and then maybe the last question, do we ever seen rheumatic heart disease plus ASPGN?
I have never seen that, but I'm sure it's probably been described. You know, I have seen children with you know, heart failure and significant cardiac issues related to their volume overload, but I've never seen anyone who meets the criteria for rheumatic fever and also have a GN at the same time.
Okay, thank you very much. There are many, many more questions, but I think we have to close the session, but we can forward them to you, or maybe you can be also
okay. Like, you know what, you can forward them to me. I'll try to answer them all. Okay,
thank you. So then thank you very much. And here the next webinars are listed. The next one will be on May 11th from Savinus Xiasi. Okay, then thank you very much and have a nice afternoon. Bye.
Bye, everyone.